process as well. Everyone today will receive either a CME certificate of health or health profession certificate, which they can submit to their board for credit. So this is the structure of our ECHO sessions, and it will follow this kind of same structure at each of our sessions with starting with welcome announcements and introductions, moving into a quick 15 to 20-minute didactic presentation, and then case presentation by one of our attendees, followed by collaborative discussion, followed by closing and reminders. So just to note, just a few house rules. Please be sure to mute yourself when you're not speaking to prevent background noise. Always introduce yourself prior to speaking with your name and location. And since we are discussing patient cases, we always want to make sure we're maintaining confidentiality and making sure not to include any personal health information. This session is being recorded, and so we do like to make sure that we share our sessions with some of our ECHO attendees who might have missed the session. So just to let you know, this session is being recorded. This project is supported by the Health Resources and Services Administration of the U.S. Department of Health and Human Services. This information or content and conclusions are those of the author and should not be construed as the official position or policy of HRSA, HHS, or the U.S. government. And none of our faculty members have any financial disclosures at this time. So I wanted to start off by just going over what an ECHO is, because this is our first session in our series. So I wanted to let you know that Dr. Sanjeev Arora from the University of New Mexico first started Project ECHO in 2003 because he was frustrated he could only serve a fraction of hepatitis C patients in his state. So he ended up creating a free educational model and mentored community providers across New Mexico on how to treat the condition. So this ECHO model has now spread, and there's over hundreds of hubs, or what they like to call hubs, around the world, with hundreds of practitioners having received specialized training and in turn impacted hundreds of thousands of patients that have now been reached with this specialty knowledge and expertise. These hubs have many different specialties, and you can essentially start an ECHO for any subject matter. So here at UCI, we have an autism ECHO, and we have specialists from our geriatrics ECHO, which you are attending today. The ECHO model is not a traditional telemedicine where the specialist assumes care of the patient, but is instead telementoring, which is a guided practice model where the participating clinician, which is you all, retains responsibility for managing your own patients, but hopefully will utilize the knowledge received from the Tele-ECHO clinic when treating your older adult patients. So as you can see, it's a collaborative, interactive learning model consisting of hub teams, which is the host, and which is us here at UCI, and the spokes, who are primary care providers and other healthcare providers interested in the care of older adults. The interactive part of an ECHO comes from having participants submit cases for discussion, and as a group, having consultative discussions about the case. You'll get to see our first case discussion towards the end of the session, and you can later ask questions about how you can submit a case if you choose to. So I do, usually we like to have everyone take the time to quickly introduce themselves, but since we have so many people on the line, we'll go ahead and have you all introduce yourselves via the chat function today. So please list your name, your role, your site and location if you can in the chat. And while you do that, we'll go ahead and have our hub team introduce themselves on video, and so you can get to know us. So my name is Nika Seville. I am the project manager for our geriatric workforce enhancement program here at UC Irvine Health, and we're located in Orange County, California. Go ahead, our members of our hub team, if you would like to introduce yourselves.
All right, well, I'll start. I'm Lisa Gibbs. I'm the Chief of Geriatrics here at UC Irvine, and we're so happy to see all of you joining us today. So thank you.
Welcome, everyone. My name is Sonia Sagal, and I'm a clinical professor in the Department of Internal Medicine and the Division of Geriatrics. And it's my pleasure to welcome you all today.
Hi, I'm Tanya Gurovich. I'm a clinical pharmacist. I work at UCI Senior Health Center, and I teach geriatric pharmacology at USC Pharmacy School.
Welcome, everybody. I'm Camille Fitzpatrick, and I'm the nurse practitioner at our UCI Family Health Center, where we have family medicine residents, nurse practitioners, and it's a wonderful clinic that we love, and I hope someday you all get to see it. Welcome.
Hi everyone, welcome. My name is Carlos Garcia and I'm a research data analyst here for GWEP.
Okay, and it looks like I see quite a lot of others introducing themselves from UCI, from I think South Central in Alaska, Ponca tribe in Nebraska, Northern California. So thank you all for joining and thank you for introducing yourselves in the chat. Hopefully in one of our future sessions, we'll get to have you all introduce yourselves via the video so we can get to know everyone. So we'll go ahead and move on into our didactic presentation today, which is on an intro to mental health and the effects of loneliness and isolation on older adults, presented by Dr. Lisa Gibbs, who's the Chief of the Division of Geriatric Medicine and Gerontology and Medical Director at the UCI Senior Health Center. If you do have any questions along the way during this didactic presentation, please feel free to post your questions in the chat function, or you can save them till the end of the didactic presentation where we'll be able to answer your questions. So I'll go ahead and give the stage to Dr. Gibbs.
Okay, let's move forward to the next slide, Nika. Thank you. All right, well, as noted, this is a mental health series, and I'm going to give a mental health overview today with a focus on depression and the effects of isolation. And to start off with, I'd like to say that, you know, we find a thread of ageism in geriatrics and gerontology, which is probably not surprising to anyone, but it's really palpable when we talk about conditions such as depression and memory loss, which unfortunately fall under this tendency. You know, and as the figure states, depression is not normal. It is a medical condition. It needs to be addressed. And its impact on quality of life and other chronic conditions is absolutely dramatic. Okay. Next slide, please. Now, our ECHO series are based on age-friendly health systems and helping, you know, all programs to help to build age-friendly health systems. So when we proceed through this module, we will be referring to how each of the 4 M's relate to this topic. And all of you on the call may have heard of the 4 M's. For those that may have not, the 4 M's include what matters most, medications, mentation, and mobility. So how does depression relate to these? Certainly understanding patient priorities and goals of care are very important for understanding the context of depression. So what matters is key. And during this series, we will be reviewing medications with our pharmacist, Dr. Geriatrics, used to treat depression and other mental health conditions, as well as medications that might contribute to depression. Also, depression has a direct connection to conditions such as dementia and cognition, slower processing speed, attention, and awareness. And in terms of mobility, some antidepressants have been associated with increased risk of falls, and our pharmacist, again, will be reviewing this data at a later time. So remember to think about the 4 M's with everything that we discuss. Next slide, please. So in this short talk, about 20 minutes, I'll provide an overview of depression relating to loneliness, and we'll touch upon caregiving, certain medical conditions, as well as elder mistreatment. Next slide, please. Okay, so let's start with the basics, epidemiology. So depression is not just having the blues or emotions that we feel when we grieve the loss of a loved one or a function. It is a true medical condition that is treatable. And we like to think of it as diabetes or hypertension or any other medicalized condition that we talk about. However, we find that quantifying the prevalence has been challenging. And as you can see from the slide here, there are some ranges here which are, you know, not very specific, which is why I like to say these are ballpark figures. So from the literature, we see that major depressive disorders, you know, might only be 1 to 5% in the general population over 65. However, I can tell you from my experience that it affects many more of my patients than this. Other literature says that significant depressive symptoms occur in 15% of community dwelling patients. And then we have subsets, you know, again, different literature, different numbers, but you can see certainly outpatients up to 10%, a little bit higher in inpatients, a little bit higher in those requiring healthcare at home. And for those in nursing homes with more chronic and comorbid conditions, depression can reach up to almost 50%. Okay. So major depressive disorder is diagnosed, by the way, with the same criteria we use in younger ages, but understanding how our patients express depressive symptoms may be different. So we know that asking in various ways often helps, like, have you been feeling down? Have you been feeling blue? And other ways might be a general way of approaching the subject, or even talking about, you know, how these changes relate to baseline function and activities. So those of us that have really spent our careers with older adults have learned to recognize the even subtle symptoms of how depression can manifest itself. Okay, next slide, please. All right. If we look at a Medicare survey, this was a survey of chronic condition public use. We find that up to 15% of Medicare fee-for-service beneficiaries had a diagnosis of depression in 2012. And if we look at another figure that showing the annual depression screenings by Medicare Part B, we find that they are very, very underutilized or underreported. So an internal CMS claims analysis found that less than 0.5% of Medicare beneficiaries had this benefit in 2012. I would imagine that we're actually doing it in clinical practice, but we're just not documenting it mostly in the way that they measure this. But I would also hazard to say that we are underdiagnosing this. And I think that's something that we need to keep in mind. Okay, next slide, please. So the same survey showed us different rates of depression based on age groups. So if you look at the left side, Medicare beneficiaries under the age of 65 entitled to Medicare because of a qualifying disability were much more likely to report being depressed compared to the older beneficiaries, okay? And so if you look at the two there, you'll see the blue denotes patients without depression and the gray with depression. So almost up to 50% of those under 65 with Medicare have depression compared to 13% of those over 65. So it's quite dramatic. So it tells us something about, you know, that incidence of depression in younger ages, and tells us probably a lot about their chronic conditions and how they relate to depression in these patient populations. And it also talks about or points us to the role for social determinants of health because of those beneficiaries with depression, regardless of age, these are the people that are most likely to report having trouble getting health care, obtaining prescriptions, and not seeing the doctors that they need to see. So again, this as most roads point us back to social determinants of health, and this is no different. Okay, next slide, please. We always want to look at healthcare disparities based on populations, and this particular chart is also based on claims data. And if we note here, it might be a little bit difficult to read, but the highest incidence of depression we find in the American Indian, Alaska Native populations, followed by Hispanic, non-Hispanic white, Black or African American, followed by Asian Pacific Islander. So again, this is what is being reported on claims data, meaning that these people have been diagnosed and are being treated for depression. What we don't know is how accurately this reflects true incidence, because of course we still feel like there's a lot of underreporting and underdiagnosis. So we'll need to keep this in mind as we move through. Okay, next slide, please. So this theme of underdiagnosed and undertreating is going to be thread through this series. Again, the diagnostic criteria is not different. However, healthcare providers may mistake an older adult symptoms as just a natural reaction to illness or life changes, and therefore not see the depression as something that really needs to be treated. And it is very frequently attributed to medical or cognition issues. The problem too is compounded by the fact that older adults themselves share this belief often and do not seek help because they don't understand that they could feel better with appropriate treatment. And just to reinforce this, I remember a patient of mine who had a very traumatic childhood, and without getting into too much detail, married the perpetrator of some abuse, went through an entire life with an anxiety disorder. And finally, after enough discussion in her 80s, you know, she told me about this story, which she had hidden from her family all this time for decades. And so we decided to try an antidepressant, and she came back and she said, I just had no idea how my life could be different. So finding these, you know, finding depression that needs to be treated is also very rewarding. Okay, next slide, please. And as you know, we all probably know, depression is also associated with other psychiatric conditions such as anxiety. The prevalence in depressed older patients is thought to be about 10 to 20%. The association with alcohol use disorder, 3 to 4 times risk of alcohol use disorder compared to non-depressed elders. And of course, we have other psychiatric diagnoses, which include depression with psychosis, depression associated with cognitive disorders, and so forth. Okay, next slide, please. Now, we can't talk about depression without addressing the suicide risk. We all know that suicide risk is high in older adults. This data and these trends have not changed in the last decade or two. Sorry about that. We also know, so from the first reference we find from 2018, that older adults accounted for nearly 1 out of 5 suicide deaths in this country. More than 80% of these suicides were among men. Okay.
Whoa.
Interesting points about this too, as among the attempts, the elderly are most likely to succeed. Okay. Firearm availability doubles the risk. And, you know, we've done some work here in Orange County, finding out where most of our older adult suicides occur. And we narrowed it down based on coroner's data to 2 areas. One is Laguna Woods, which is a very dense older adult community. And the other is Huntington Beach, which was fairly surprising. And we haven't really narrowed this story down much more detail, but we do know that Huntington Beach is an area with a lot of retired military and law enforcement, probably a lot of access to firearms. Also, with older adults and others, we notice that if ideation is present, there's a higher risk of committing suicide. And we also know that if patients don't talk about it, but they're thinking about it, there's a higher risk that they will do it. And, you know, again, with COVID, we know that the suicides have increased in Orange County, as they probably have everywhere in all ages. But one tragic story that we faced a few months ago was a couple who were very well off. Unfortunately, they had a loving family and they had a lot of support, but they decided to check into a hotel, and they had a plan, and they both overdosed, and they had, you know, they had explanations, they had letters for the family and everything else, but they had not mentioned that they were even considering this, and the family was just stunned. But we were reviewing this later in our elder death team, and we're like, you know, it's true. The people that don't even talk about it and have already decided that they're going to do it, most likely do it and are successful. Also, depression and suicide risk is higher in the first year after the loss of a spouse. And this is something that we can really pay attention to with our own continuity patients who we know have suffered a loss of a spouse. Okay, next slide, please. Again, just some information from Orange County, which may not relate to every region in the country, but it does show the trends that we find in the literature. So on the first set of bar graphs, you'll see all ages within Orange County. The blue is all, the green is males and the orange is females. And then as we move towards older adults over 65, you can see all these bars tend to increase. If we go to older adults 85 and over, we see a dramatic increase in suicides among men, a fairly dramatic increase in suicides among women as well. So, and if any of you are working in public health in your regions, you know, this sort of data can be available again through the coroner's office and can be a source of really looking at some details within specific communities so that you can devise some interventions. Okay, next slide, please. Let's talk a little bit about contributors to depression. Older adults face very unique situations contributing to the risk of depression and anxiety. And change is just a constant, you know, in older age. There's changes in social circles, changes in retirement, medical conditions, grief and loss, and loneliness. Unfortunately, we have a high rate of elder mistreatment across the country. And there's a lot of issues around caregiving to depression. So I think we should, you know, expect that as people go through becoming older and potentially losing loved ones and accumulating comorbid conditions and facing the loss of function, you know, these are not easy things to go through, yet we rarely pay much attention to how we're going to help people through these periods of change and adjustment. Okay, next slide, please. All right. Let's talk a little bit about a few of these in a little more detail. I'd like to talk about loneliness. It's something that gerontology is paying a little bit more attention to in the last decade. And we know now that loneliness is a risk factor for poor health outcomes, including functional decline and death, and increases the risk for depression, no doubt. And in this particular study, found that 43% of the community dwelling population was at risk for or had loneliness. And if you compare that to, you have to think about, if we compare that to depression, thinking that 15% of the community dwelling have depression, you have to wonder too about how those questions are asked and how many people who are lonely are depressed, because potentially the rate for depression could be higher. Someone has also, researchers have looked at the effect of loneliness on health and have compared this to as being as dangerous as smoking 15 cigarettes per day, which is a really stunning statement because we know how damaging cigarette smoking can be to our health. And I often find that this is really helpful to explain to patients and families as well, because it really puts this in a context where people can really, you know, understand that it has huge impacts. Okay. All right, next slide, please. In the age of COVID, obviously we have much more difficulty, you know, with social connectedness. And our COVID precautions have added tremendously to loneliness and isolation. We, in our clinics, are seeing this effect in patients and sometimes asking whether the cure or the prevention is worse than the disease. Next slide. We have a reason to enact these precautions. We know that the death rates confirm this. And this is a picture showing that, you know, as the age deciles increase, the death rates increase dramatically. So we know that COVID disproportionately impacts older adults. For instance, of the 12, but now at the time of that I looked this up, it was 1,264 deaths. Now it's much, much, much higher. But at that point, 74% of the deaths were in people over 65 and 32% were in people over 85. So right now, California is going through an immense crisis. And in our senior health center, which is a clinic which is devoted to the care of older adults, we're getting daily notifications of our patients' deaths at this point. So it's really pretty dramatic and sad at this point. So we need a public health approach, but patient by patient, we've seen the damage also of isolation in this population. Next slide. So the increased stress due to isolation is seen in all settings. And the most severe impact we have seen has been in congregate living communities. We all know that for folks in nursing homes, their patients' families are no longer able to visit. Families see each other through glass or not at all. I've had experiences, as well as all of our other providers. Specifically, one couple I remember both descended into severe depression after a husband was admitted to a nursing home after hospitalization, and his wife was left at home, and both of them just, again, descended into a severe depression. And I don't anticipate that either one will ever come back to a meaningful baseline. Isolation also affects the utilization of healthcare. So we know that those most needing our healthcare may not be visiting healthcare providers. And that includes, being treated for depression. For those who rely on in-home help, the situations are even more tenuous. All of a sudden, families prevented outside caregivers from coming in due to the risk of exposure, or the caregivers themselves became sick. And many caregivers we know are from minority underserved populations and have a much higher rate of illness in those populations as well. So you can see how, COVID has just compounded this ability to care for our seniors in an adequate manner and has contributed to their isolation from society. Next slide, please. And finally, the closure of the senior centers has impacted our families tremendously. Again, patients no longer have this outlet for socialization and nutrition. And families and caregivers, many working from home, have no respite. Or even worse, sometimes family members have to quit their jobs to care for seniors who are now at home 24 hours a day, 7 without any relief. Okay. Next slide, please. We know too from seniors themselves that this has had a big impact. This graph is actually from early in the COVID epidemic, or pandemic, excuse me. This is a survey of older adults themselves, revealing an increasing trend of increasing stress with negative impacts on mental health. And again, this is early, starting from March, May, and through July of last year. So we know that this is much, much higher at this point. Okay, next slide, please. Again, just to round out an overview, many medical conditions are also associated with depression. For instance, it's an established risk factor for the morbidity and mortality of patients with heart disease. Up to 25% of those with heart disease experience major depression. In terms of heart failure, they know that after 24 months, a depression score is a significant indicator of mortality. And so, on and on, we know that there's a high risk of depression status post-stroke that often needs to be treated. And the effect of depression on chronic diseases like diabetes is well understood in terms of, the self-management of diabetes and so forth. Next slide, please. We can't leave a talk like this without mentioning depression and dementia. This is really a subject that is close to our hearts because we care for a lot of patients with dementia. And when we talk about situational loss, it's not just the loss of memory and ability to participate in a meaningful way, but sometimes we find that because people have dementia, they're labeled and they're uncomfortable with their groups of friends. The friends don't treat them the same way. They have to experience changes in living arrangements that they would not have ordinarily chosen. So it's important to remember that, you know, we have movements now for dementia-friendly environments, and they're so important because they teach us and remind us to be inclusive of patients with, persons with dementia. In other words, we need to continue to normalize some of our interactions instead of labeling people and excluding them out of our awkwardness or inability to relate. So in fact, I don't know if Megan's on here, but I know Megan sent, one of our nurse practitioners sent a video of a cafe, I believe it was in Japan, where they actually open up to serve persons with dementia as if, you know, nothing had ever changed. And it really makes people feel wonderful just to be able to go out and order a meal like they used to and sit with their families. And even if mistakes are made, it doesn't really matter because the waiters and everyone, you know, treat everyone like, you know, there's no problem. So just a reminder again, I think not only the dementia itself, but the situations that dementia places people in really, you know, increase that risk for depression. But we can do a lot about it in the way that we work with, we communicate with, and we keep our loved ones with dementia socially connected. All right, next slide. Okay. Sorry about that. They've been quiet for days, and all of a sudden, they have to speak when I'm speaking. So, we have also, I just wanted to mention the importance of sleep. We know that insomnia increases with age, up to 25% in men and 40% in women. But it is a risk factor for both the onset and persistence of depression. And, you know, again, it's about raising awareness of the importance of sleep. We know that sleep helps secure memories, helps our brain organize information and experiences. I just learned yesterday that if you sleep well after you get a vaccination, it helps your body establish an immune response to that vaccination. And we know that conditions such as sleep apnea have chronic impact on our cardiovascular systems and so forth. And not the least, but it has a huge effect on our mood. So again, when we talk about depression and treating depression, we have to pay attention to sleep as well. Okay. And lastly, with regards to just pointing out different scenarios, we find that depression is both a risk and a consequence for elder and dependent abuse. For every single type of abuse you see here, depression can place one at higher risk for that abuse, and depression can be a consequence of abuse. This is something that we don't have time to really get into detail, but certainly we have to also be mindful of the risk for elder mistreatment with our patients. Okay, next slide, please. And just a couple of notes about caregiving. We would be amiss if we didn't address caregivers with our discussions of older adult care. These results are from a survey of caregiving in the United States. And the question that was asked of caregivers was, how emotionally stressful would you say that caring for your relation or loved one was for you? And from the results above, you see that 38% are highly stressed, while 26% are somewhat stressed. But in this population, the stress, of course, leads to depression and other negative consequences. Next slide. And I think we've all seen the effects with delays in medical care, increased rates of chronic conditions, financial concerns, mental health, and altering life courses. In fact, this was even, you know, highlighted in an article about caring for persons with dementia. That 3/4 of dementia caregivers reported being very concerned about maintaining their own health. 45% endorsed a negative financial impact, with some even having to use up savings and borrow money to pay unpaid bills. And so approximately even 40% of family caregivers with persons with dementia report depression. So very high risk of depression in caregivers. Okay, and last slide. Again, this has been a short but rapid overview in depression, but I just want to end with a slide of hope. Moving forward, as we go through this series, we'll have some enriching discussions, but I'd like us to keep in mind what healthy aging looks like. Growing older is really all about adapting to constant change, and this is always going to take resilience and the ability and openness to adapt for healthy aging. Those we find who do it best continue to have purpose in their lives and are able to express what matters to them and really manifest that in their lives. And again, social connectedness is necessary for all forms of mental health. It's most challenging right now during COVID, but hopefully we've all learned as a society, what we need to do to stay healthy and stay socially connected. So with that, I will end and turn this back over to Nika, who can take us into the next case.
Yeah, thank you so much, Dr. Gibbs.
Mm-hmm.
Does anybody have any questions for Dr. Gibbs? You can feel free to speak up or type your question in the chat.
Or questions can even come up during the case discussion where we'd like to have more of a discussion among all of us.
Okay, we'll go ahead and move on into the case overview. So we'll go ahead and this case will be presented by Dr. Catherine D'Azambuja, who is a geriatric fellow here at UC Irvine. And she'll go ahead and give a quick summary of her de-identified patient case. And we'll refer to this patient as patient number 208. And you can give me a second to just pull up this case and we can go ahead and have Dr. D'Azambuja give a summary of that case. So 1 second, please, as I share my screen. Can everybody see this?
Mm-hmm.
Okay, great. We can go ahead and get started. Dr. D'Azambuja, you can go ahead.
Okay, thank you, Nika. Hello, everyone. My name is Kat D'Azambuja. I'm one of the Jerry Fellows here at UCI. I do have a case to share with you all today. It's a case that I had when I was working at the VA in Long Beach on the inpatient psych, the Geriatrics service. So this is a patient who, a 72-year-old male, who was admitted to the inpatient psych unit for uncontrolled depression, anxiety, insomnia. So a little bit of background on this patient. He has a history of PTSD, depression, moderate alcohol use disorder in partial remission. His last drink he had mentioned was a few months prior to the admission. And a history of suicidal ideation, no suicidal attempts, and uncontrolled depression. So he was brought in by his family for persistent low mood, anhedonia, insomnia, and weight loss of about 30 pounds in the prior 4 to 5 months. He says that initially when he came into the hospital, the patient reported feeling like his mood was worse because of the pandemic and feeling isolated. He would endorse moments of quote unquote wanting to drive off a cliff because he was very depressed, although he had denied any prior suicidal attempts, and this was confirmed with his family. And his goal was to be admitted to the inpatient service with psychiatry to try to control his insomnia, his anxiety, and his depression, and he wanted to get his life back together. He was sleeping maybe 2 to 3 hours a night per the patient. Prior to the admission at the VA, he was admitted at an outside hospital for about a week and a half, maybe a month or so before he was admitted to us for similar presentation. And they had discharged him on some medications for his anxiety and depression. One of them was escitalopram 10 milligrams daily, along with Ambien 10 milligrams in the evening. He was also prescribed a prescription of methylphenidate, 20 milligrams, which the patient actually stopped within a few days because the methylphenidate actually made his anxiety worse. When we asked him about diagnosis of things like ADHD or reasons why he was started on the stimulant, he denied any real diagnosis of ADHD, and we couldn't really confirm that with the outside hospital. In addition to those medications, he was also taking lorazepam 1 milligram twice a day, which he had received a prescription from an outside provider, not from the prior outside hospital and not from the VA. So a little bit about his medical history. In addition to his the psych history, he had a history of COPD, OSA, not on CPAP, high blood pressure, CHF, peripheral neuropathy, BPH. His social history, he was a divorced person. He lived with a 24/7 live-in caregiver that was paid by his family. So he lived in a house, but with a caregiver with him at all times. And his depression screening on admission was a PHQ-9 of 24, which was very significant for depression. So initially when we admitted him, we were trying to control his anxiety, his insomnia, his depression, and also the substance use, substance abuse history, and the concern of using Ambien and Ativan. His brother, who was one of the family members who brought him in initially, was worried that the patient was self-medicating and using, and was afraid that he would become addicted to the Ambien and Ativan. So that was a big concern for the family. So we talked to the patient initially when we admitted him, and we did taper him off the Ativan safely within a week and stop the Ambien. But we did replace the Ambien with a different Z drug, which was the ezopiclone, which is a little more long acting. We also tried medications like trazodone to help with the pain, with the insomnia. And for the depression and the PTSD, we started him on a different SSRI, which was sertraline 50 milligrams. And over time and throughout the hospital course, in regards to the anxiety and the insomnia, that was something that was persistently still a problem for the patient. Objectively, he was sleeping more, according to the nursing staff who had eyes on him all day and all night. He was sleeping, according to them, at least 6 to 7 hours. But in the morning when I would speak with him, or any other providers would speak with him, he reported sleeping 1 or 2 hours a night. So he felt still very anxious and unable to sleep. Unfortunately, there was an incident on hospital day 3 where it was found that he had clonazepam with him. I think he had it in his clothes, and he did somewhere in his pockets, and he did take a pill of clonazepam. So we were able to take that away from him, and had a serious discussion about the need to be upfront with us about what medications he's taking, and really trying to educate him on the reason for his insomnia, and really trying to educate him on medications that we feel wouldn't be helpful. If anything, would make things worse for him, and especially given his anxiety, his history of substance use, and his history of being elderly. So he has a lot of risk factors for using medications that we would be afraid would make things worse for him. So we had a family discussion on hospital day, I think it was hospital day 7. We talked to his family, his brothers, and to get a sense of what their goals of care for him were, or and what the goals of the patient was at that time. Again, the patient wanted to control his anxieties and insomnia, and the brothers wanted to also help with that, but were afraid that he has a lot of self-medicating behavior from his alcohol use disorder, and they were afraid that if we would discharge him, he would go back to that sort of behavior. So we talked to the patient at length. Every morning we would talk to him and really try to educate him on what's going on, what is anxiety, what's going on in your nervous system, and really trying to educate him on the medications that would be most helpful, and things that would be helpful would be like therapy. So we were able to connect him with the substance abuse treatment center at the VA through telephone calls, and he was able to follow up with them through telephone calls while he was on our service, and eventually discharged home with his family and continue with that treatment and with their resources. So when we discharged him, the medications we continued him on was the sertraline for the anxiety and the PTSD. We up titrated it from 50 milligrams to 150 milligrams. He was also sent home on the azopiclone 2 milligram at the evening dose, which is the max dose for that medication. And then also hydroxyzine as needed for anxiety attacks. And I guess the reason I brought up this case for today was I personally had a lot of difficulty with trying to really engage the patient in what's going on, and really trying to educate him on his anxiety, and really trying to get through to him about his underlying alcohol use, and trying to keep him away from self-medicating. So I did find a lot of resistance myself and the psych team, along with his family. So the reason I put those questions on here, one of the questions that I had was, what alternative interventions would be could be suggested in treating uncontrolled anxiety and insomnia in an elderly patient with a history of alcohol use and benzo abuse. My second question was, any other suggested treatments for uncontrolled primary insomnia that are not controlled on non-benzo medication. So in his case, we had tried trazodone, that didn't help. We had tried, we took him off the Ambien because it's short acting, and we didn't feel that would be very effective. So we started him on azopiclone, which is a little more long acting, and he subjectively felt it wasn't really helping. And then my third question, if there's any any suggested strategies in caring for a patient with a history of substance abuse, in his case, alcohol abuse, who are not cooperative with seeking treatment. And I think this was the biggest problem, because I think a lot of his underlying issues were because he wasn't cooperating with us and trying to seek the therapy that we were suggesting. And I can feel that his family had gone through a lot of the same things over and over again with other providers, other inpatient teams as well. So these were my questions for today's case.
Thank you, Dr. Azambuja. So as a collaborative team, does anybody have anything to say about her questions or would like to weigh in?
I have a question. What was the trazodone dose you guys tried?
The trazodone that we tried was, let me see here. I think it was 50 milligrams initially.
Did you go up?
We did go up. Let me see. We up titrated to, to 150 eventually.
Okay. And did you ever try a Remeron or mirtazapine?
We did not.
Okay.
No, we didn't try that one.
So that usually helps with sleep, weight gain. So that might be the better choice. Occasionally you can up titrate trazodone to 200. That would be the max I would be comfortable with. Okay. But the things that he's complaining about, the subjective lack of sleep, that actually happens with all the benzos and Z drugs, because what they do is they block REM and delta sleep, and they really create this lack of sleep memory. So you don't remember sleeping and you think you're not sleeping. I find I see that with patients in the clinic. Obviously, this is a more severe case, but in clinic, I see patients like that all the time, where they say they're not sleeping and the family member is saying, oh, but wait a minute, mom, don't you remember you did sleep? And so that's very common.
Okay. Now that I remember, Dr. Gurvich, the reason why we ended up stopping so we started him on trazodone 50, up titrated to 150, but the reason we stopped it was because he had a very particular side effect to it. He said that it would cause some sort of like coughing, which is not a typical side effect, but he was adamant about trazodone causing that, so we stopped it a little early. And then the mirtazapine, there was no contraindication. I'm trying to think of why we didn't start it. He was overweight, and I know there was that 30-pound weight loss, but he was a little more of a
Okay.
person.
Okay.
Can you talk a little bit about how you ended up with hydroxyzine for anxiety?
I think that was something that was added by the nocturnist as a PRN, and something that my attending was agreeable to, in terms of like at least something that the patient can take as needed for anxiety. He didn't feel comfortable with anything else as like a PRN order for anxiety for him.
Dr. Gervis, what do you think about that? I mean, it's such an old medicine. We know that, you know, it has side effects that we're not particularly happy with, but, you know.
It's sort of off-label for anxiety, I think. I don't think it's ever been FDA approved for it. It is an antihistamine with a potential, first generation with potential cognitive impact. So not my first choice, but I do know that occasionally it is used. It just depends on how he tolerates it. I mean, I would think it's probably, I mean, I would rather him be on that than on Ativan if that's the choice. The other option for anxiety, I guess, would be Buspar. I don't know if you ever considered that. Sometimes it can be effective. It just takes a little while to kick in.
I think we were thinking that the SSRI would help with the depression and anxiety. And I know for the SSRI doses, typically higher doses are for anxiety. But we did start with like a lower dose of the sertraline initially, thinking that would help with anxiety and the depression and the PTSD. The Buspar, that's kind of what you would take daily, so it's not an as-needed medication.
Right.
So I think the hydroxyzine was more like something that the patient could ask for, because he was asking the nocturnist many nights for something to help him sleep and for the anxiety. So that's why we told the nocturnist to hold off any extra like Ambien, no benzos, and that's why the hydroxyzine was added.
Okay.
There's a question.
We do have two questions in the chat. One is from Jim Milbury, who said, was there discussion on meaning of ETOH abuse in family?
So during the family meeting, we did discuss that with them about, you know, what that diagnosis means. And they understood, and they were very, very involved in his care. I think their concern was in addition to the history of the alcohol use, was his self-medicating behavior. And they knew that he needed maybe some sort of inpatient substance abuse care, somewhere where he can, like a rehab of some sort. But a lot of those places required that the patient be willing to be there. So we had a lot of difficulty with the patient agreeing to go to those sort of facilities. It's like he wasn't really agreeing with he didn't want to agree with that diagnosis. And then the question.
And what?
Well, I just wanted to go back to Jim and see if that was what you were, if that answered your question, or did you have another take on that?
No, it answered my question. Sometimes, you know, I mean, we all know that a lot of times it can have a no talk rule when there's substance abuse, depression, no talk rule. It's kind of wondering if that played into it with the brother especially. And then he's hospitalized for this. So then there's the increased anxiety and that social changes that's going on in the family dynamics because of the brother's alcohol abuse, use, and misuse with his self-medicating.
All right, thank you.
Thank you.
And there's a similar question also in the chat, that was there a discussion with the patient regarding what he was self-medicating for?
Oh, the anxiety. The anxiety, mostly anxiety and the insomnia.
So study after study shows that non-pharmacologic approach to insomnia is really best, like sleep hygiene. So was he like, did OT talk to him, or a counselor talk to him about his routine and kind of things you can change? I mean, I realize that it's a really severe case and this may not work, but in less severe cases, I think sleep hygiene can be quite effective, and more so than medications in many cases.
Yeah, and absolutely, Dr. Burbidge. So in his case, either myself or the attending, I remember sitting with him and explaining sleep hygiene. And he would understand, but again, he was really difficult. He would always ask for medication. He would kind of wanted a quick fix for what was going on. And we really sat him down and explained what's anxiety. Like, we try to explain that your sympathetic nervous system is kind of on overdrive, and a lot of it just didn't really get through to him. And maybe it's something that I just need to work on in terms of explaining things for patients to understand. But we did talk about sleep hygiene, and in terms of like therapy, we did offer speaking with a psychologist, and then because of his alcohol abuse history or use disorder, we ended up connecting him with a substance abuse treatment center at the VA. So he did end up having phone calls with group sessions.
I know we're short on time, Nika. Maybe one more, Dr. Grivich, could you talk a little bit about the acesulfame for sleep?
So it's a Z drug. It's very similar in mechanism of action to Ambien and Sonata. Ambien is sort of, they all have fairly quick onset of action. Sonata has a slightly quicker. Lunesta is also really quick. It's within 15, 20 minutes. The difference with Lunesta versus all the others, it's got a little bit of a longer duration of action, and it was actually studied for a slightly longer period of time in clinical trials. So it's usually indicated for longer term insomnia. Now, whether or not that's sort of a little marketing spin on it or not, I don't know. Mechanistically, it does the same thing. It extends stage 2 sleep, which is less deep. It shortens REM and it shortens delta sleep. And so the result is you do spend more time asleep, but you don't necessarily feel like you've slept when you wake up in the morning. So you're not necessarily well rested or remember sleeping. So you don't dream as much and you just don't have that sleep memory. So it's not really that different from Ambien, except that it's longer acting. So in response to Lunesta coming out, I think Ambien started to come out with long extended release Ambien, or these funny formulations where there's a little bit of it released right away and then the rest of it over a longer period of time. But they're all relatively short acting compared to a long acting benzo, for example. I hope that makes sense.
Mm-hmm.
And just one final comment about his insomnia. The other thing that we were thinking about was untreated OSA. Oh yeah, that's the last question. Yes, so that was addressed. I did talk to him about that and how OSA can definitely cause a lot of his insomnia. So we did schedule for an outpatient sleep study to be done before when he was discharged, since he can't get that done while he's on the inpatient psych service. But that was something that we definitely took into consideration as probably one of the factors contributing to his sleep problems.
Thank you so much. Anything else before we close out the case? I know I just have 1 or 2 slides to close out the session. I know we're out of time.
Good job.
Thank you so much, Dr. Dazan-Buha. I did want to remind everybody that remember the interactive portion of these sessions are due to the case discussion. So if you ever want to submit a case, we welcome them at any time. So just remember, not all sections in the template need to be filled out, and it can be a simple case or a complicated case. So I'll be sending out the template for the cases if you'd like to submit a case. And let me go ahead and share my screen again so I can take you to the last slides so you can be sure to receive CME credit or CE credits. So if you wish to receive CME or a health professional certificate, please fill out the form at the following link. I will go ahead and send another reminder with these links as well. And we'd also love it if you would fill out an evaluation form to help us with our continuous quality improvement efforts. And you can also submit suggested topics for future ECHO sessions as well. These CME and AHP certificates will arrive via email about a month later. I'll also send certificates at the end of the series for completion of series and gaining expertise in age-friendly geriatric care. So as a reminder, our next upcoming session is on January 22nd on the topic of mentation and medication, depression, anxiety in older adults. And that's going to be led by Dr. Sonia Segal and Tatiana Gurvich. So we are very excited to have you all and hope we'll see you at our next session. If you do have any questions along the way, don't hesitate to reach out to us at any time. We'll go ahead and be sending reminders for the session via email. Does anybody have any last minute questions before we end this session? I want to thank Dr. Gibbs and Dr. Dazambuha again for leading this session, and we hope to see you all on January 22nd. Thank you all so much for taking the time to be here today.